Distinguished guests, ladies and gentlemen, welcome to the Innovations of Transforming Cardiovascular Health and Stroke Outcomes panel at the Science for Life Symposium today. This is an event in the framework of VinFuture Scientific Week, VinFuture Award Ceremony 2024. Thank you very much one more time for being here with us today. Welcome all of you. Distinguished guests, ladies and gentlemen, the VinFuture Prize is a prestigious global award committed to advancing science and technology for humanity. The VinFuture Prize 2024, with the central theme, Resilient Rebound. The 2024 prize seeks innovations addressing urgent global challenges like climate change, healthcare crisis, and resource shortages, driving sustainable development. And the topics we'll explore in today's panel are essential for advancing global scientific progress and have profound implications for human life. Cardiovascular disease and stroke remain among the leading causes of mortality worldwide, posing significant challenges to healthcare systems and public health. Vietnam is actively striving to address these challenges through innovations and collaboration, aiming to improve health outcomes and enhance quality of life. To disseminate scientific and technological knowledge to the public and connect generations of young scientists, inventors, and entrepreneurs with globally established inventors for potential partnerships, the event today is held with the participation of distinguished speakers who have excellent expertise and experience in the field of public health and cardiovascular diseases and stroke care. In addition to our speakers today, we also welcome many representatives working in the field of science, technology, and also from government. We are honored to welcome Professor Sir Richard Henry Friend, the chair of the VinFuture Prize Council. Thank you very much. Maybe he's outside to connect with other scientists, and later on, he'll be here to discuss with us. We are honored to welcome Dr. Lê Thái Hà, Managing Director of VinFuture Foundation. We are honored to welcome Professor Alta Schutte, University of New South Wales and George Institute for Global Health Australia, and also the member of the VinFuture Prize Pre-Screening Committee and will serve as the chair of this panel today. Welcome. Ladies and gentlemen, and now let's have a moment to introduce today's topic and get acquainted with our chair and our distinguished speakers through a brief video. And brief video, please.
Cardiovascular diseases stand as the world's foremost cause of death, impacting over 500 million lives across the globe. In 2021, these diseases claimed 20.5 million lives, nearly 1/3 of all deaths worldwide, an increase from the previously estimated 121 million cases. Heart attacks and strokes account for a large share of these fatalities. While up to 80% of premature heart attacks and strokes are preventable, 80% of cardiovascular deaths occur in low and middle income countries due to limited access to essential care. Prevention depends on addressing key risk factors, including tobacco use, unhealthy diets, physical inactivity, harmful alcohol consumption, and air pollution. Innovative interventions, including single pill combinations, team-based care, and potassium-enriched salt are driving impactful changes in cardiovascular health and stroke outcomes, while digital health expands preventive care and early diagnosis in resource-limited regions. All of which will be explored further in this symposium. Presenting and chairing this panel is Professor Alta Schutte from the University of New South Wales and George Institute for Global Health, member of the VinFuture Prize Pre-Screening Committee. Joining the panelists are Professor Valerie Fajan from Auckland University of Technology, co-chair of the Global Policy Committee of the World Stroke Organization. Associate Professor Na Quang Nguyen, Vice Director of the Vietnam National Heart Institute, Bach Mai Hospital. Professor Duc Phu Bu, Director of Cardiovascular Specialty and Chairman of Cardiovascular Committee at the VinMec Healthcare System, Associate Professor Du Ton Mai, Director of Stroke Center, Bach Mai Hospital. Under the theme Resilient Rebound, the 2024 VinFuture Prize Award ceremony aims to discover outstanding advancements in science and technology. This symposium will highlight pioneering progress in cardiovascular and stroke care, focusing on innovative treatments, preventive strategies, and technologies set to reshape global health standards. Let's come together to unlock a future where quality care and healthier lives are accessible to all.
Thank you very much for your attention on our introductory video. And now please join me in welcoming to the stage Professor Alta Schutte, Sharp Professor and Principal Theme Lead of Cardiovascular and Metabolic Medicine in the Faculty of Medicine and Health at the University of New South Wales, Professorial Fellow of the George Institute for Global Health Australia, to deliver the first presentation on novel approaches to transform global blood pressure control. So Professor, please.
Thank you very much and welcome everybody. I am truly delighted to have a session on cardiovascular disease as part of this Science for Life Symposia of the VinFuture Foundation. I think we've seen many technologies and very exciting developments here, especially in the field of infectious diseases, but I do think that cardiovascular disease and non-communicable diseases needs our attention, especially since we know that there are novel approaches to also address these challenges that we are facing. So yes, my focus will be specifically on blood pressure control, and I will be followed by two distinguished speakers. You've just heard about them. We'll focus on stroke prevention and then on acute care pathways for stroke and stroke rehabilitation from the local experts here in Vietnam. So to start off with my presentation on blood pressure control, which is the area that I'm focusing on in my research, I would like to first emphasize why I have decided to focus on blood pressure control specifically, and maybe want to ask a bit of a root question to the audience, and that is, if you can put your hand up if you're older than 50 years of age, would you please do that? Right. Thank you. That is many of you, and I do think that means you have a 50% chance to have high blood pressure or hypertension. And as we get older, it's 60% roughly, and 70 or more percent actually of people get high blood pressure or hypertension. So it's in our age, it's normal to develop high blood pressure as we age, but in previous populations that was not the case. So people got older without having elevated blood pressure. So this is one of the challenges that we have to face today. And high blood pressure is not something that we can just leave as it is, although it has no symptoms, which is one of the major challenges, having no symptoms, so it's very hard to diagnose. But, and I will use a slide here from our next speaker, Professor Fagan, on why I want to focus on blood pressure control. Because if we focus on specifically stroke and the key risk factors for stroke, you will see there at the top that high systolic blood pressure is by far the leading risk factor for stroke. And we've had a great session today about air pollution. You see air pollution there in the second spot. Also household air pollution and smoking being key contributors to stroke prevalence. And therefore, it is important to focus on especially high blood pressure and managing it much, much better than what we are doing today. Because high blood pressure leads not only to stroke, but also to heart attacks, to dementia, and to kidney disease. So if we were to eliminate the problem of high blood pressure, we would certainly have much longer and healthier lives. So it has been mentioned today also that air pollution is the second leading cause of death, and in that case, that is systolic blood pressure is the leading cause of death in the world, leading to more than 11 million deaths each year. Almost 20% of all deaths are related to high blood pressure, and it is much more, indeed, as was said this morning, than what we've ever seen in terms of COVID, when the world acted swiftly and with a lot of action to make sure that changes are made. But unfortunately, with conditions such as non-communicable diseases, action is extremely slow. So when we look at the size of the problem, you have to first start with the population with hypertension. Globally, there's about 1.4 billion people with high blood pressure, or 1 in 3 people older than 18, and as we age, that proportion increases. And then we have to look at who are aware of their high blood pressure. It has no symptoms, so about 50% of people are aware of the problem, and then they have to receive treatment. So fortunately for high blood pressure, we have perhaps some of the most clinical trials have been conducted in the field of high blood pressure. So we have very effective, cheap medications that are widely available that should be prescribed. And then it needs to be controlled. So that means the patient has to take their blood pressure medication and get their blood pressure back to target level, which is less than 130 for systolic blood pressure. So the problem that we have, let's focus on uncontrolled hypertension. That means people have already been diagnosed, they have a prescription for blood pressure lowering medication, but they are not necessarily taking it, so their blood pressure remains high. And the problem with that is that we have about 23% of women and only 18% of men actually have their blood pressure controlled effectively with medication, although it is prescribed. So there's many challenges in the situation until we can get blood pressure to go to target levels. So these are the control rates for hypertension for women. That was the latest data we have. It's really for 2019. And you can see here that even in the countries that are in the darkest color, it's only 55% or so having their blood pressure controlled. So even in countries with great health systems, we still face these challenges. This is for men, and you can see low and middle income countries are significantly affected with uncontrolled hypertension, and that is why 3/4 of cardiovascular disease deaths also occur in these countries, but also they have the higher population numbers, of course. So why are patients uncontrolled? We would think that a patient with high blood pressure going to their healthcare provider, their doctor, would get a diagnosis, a prescription, go to the pharmacist and get the prescription filled and take their medication and get their blood pressure lowered to target level. That is the theory, right? But there are so many areas where things go wrong in this pathway for the patient not actually taking their medication. So often the blame is shifted to the patient, they're not taking their medication, or the blame is shifted to the doctors not prescribing as they should. And it's actually such a complex challenge, and I just want to highlight a few reasons why we are having these challenges. And the key thing here is that drugs don't work in patients who don't take them. It sounds quite logical, but it is true. We have effective medications, as I've said. We have many effective drugs that lower blood pressure very effectively. But we have a significant problem, number one there, therapeutic inertia. That is the failure of a healthcare provider, a doctor or nurse, to initiate, start, or intensify medication when goals are not met. So when the blood pressure remains high, the doctor is supposed to intensify the treatment or to at least start the treatment in the first instance, and that does not happen. Let me show you. This is data from the Netherlands. I have several other papers from other countries, including the US, that show therapeutic inertia was 87%. In other words, in thousands of patients going to their doctor having uncontrolled blood pressure, in only 13% of them, the doctor did intensify the medication. I have a study in the US where that is 90%. So in only 10% of patients, the medication was intensified. And why does this happen, right? So it's more clear on this slide when they investigated the reasons why blood pressure medication was not intensified. And I want to highlight here, firstly, the blood pressure reading will be repeated. Those in red, recent blood pressure readings were just below target, stress during the GP visit. These are all the reasons why doctors said they could not or did not initiate therapy. The blood pressure was just above the target, so probably they were just stressed during the visit and they did not feel comfortable to increase the medication, worrying the patient may have side effects. So we often ask the question, would you rather have a patient having a side effect or a stroke? So that is never really part of that discussion, because side effect discussions are always very prominent in these during these visits to the doctor. But you will see all of those highlighted in red are related to blood pressure measurement techniques, a technique that we have used for more than a century. Blood pressure has been taken with a cuff around the arm. It's very effective, it works well, and it's very accurate too, if you use the right machines that have been checked for accuracy. Unfortunately, I have to mention, when you look at electronic devices, about 80% of them in the market are not validated for accuracy. So those of you who measure blood pressure at home, speak with me if you want to know how to check whether it's accurate. But that is part of the problem, is these devices, or any form of blood pressure measured in the clinic, results in therapeutic inertia because the doctor cannot trust the values. They cannot trust the values because they speak during the measurement, which elevates blood pressure, or many other things can happen during that measurement that will affect blood pressure. There's a very strict protocol of how blood pressure should be taken, because blood pressure changes. It's higher in the winter than in the summer. It's higher in the day than in the night, or when we have acute mental stress. So there's very many stressors that contribute to changes or differences in blood pressure. From second to second it can change. And therefore the doctor don't want to trust the reading in the clinic. So we have office blood pressure measurement, the traditional one, on the left-hand side. Then we have now more home monitoring for patients to monitor it when they are calm and relaxed, or 24-hour monitoring, all using the cuff method. And now we have newer technologies called cuffless technologies, which take blood pressure almost continuously on your arm or on a ring on your finger, more technologies that show quite big potential. But they have not been checked properly for accuracy, and we are working with these companies to see whether we can get there. I'm an optimist, so I believe that can transform how we continue managing blood pressure in the future. So first, I would recommend to stop clinic blood pressure completely, because doctors can't trust it. And to switch to home blood pressure monitoring, but many things need to fall in place before we can move there. And ideally in the longer term, I hope that we can switch to cuffless monitoring once they have been proven to be accurate and affordable, and we can make them widely available. Another problem that we have is we have so many blood pressure or hypertension clinical management guidelines that doctors are often confused in how to use them and implement that effectively. We know in general practitioners, family doctors, they are very overloaded and can spend about 10 minutes per patient. So to follow and read and know all these guidelines have been quite challenging. So one of the other solutions that's been shown to be quite effective is to simply implement a one-page treatment protocol that can be developed per country. And I know it's been done also here in Vietnam. And these have been proven to be quite effective, and particularly when they've been implemented as part of team-based care. That is, nurses should be involved here, pharmacists, and here community health workers, especially since we know that doctors have a very high burden. So this is just showing millions of data points from the UK where patients have been followed for 1 year. You'll see that high blood pressure in the beginning, they had a prescription of any of those medications which are in guidelines, and they had a great blood pressure drop in the beginning and not again. And that is exactly what we mean with treatment inertia. So the target for blood pressure management in those days were 140, it's now 130. And therefore we do hope that with new guidelines and implementation of them, we will get the blood pressure down so that doctors will continue to intensify treatment until the blood pressure is at target. The second problem is that patients often do not take their medication, and there are also many reasons for that. So medication adherence is actually quite a big problem, where we see for all of these conditions, from cardiovascular disease, angina, hypertension to heart failure, that about half of patients don't take their medications after 1 year of prescription. So that's also a massive challenge. We see, for example, here that when they don't take their medications, they have an increased risk for cardiovascular events, which is expected. So one of the modern effective therapies is to use single pill combination therapies. That is, when 2 or more drugs are included in one capsule, and they have much better longer-term adherence because it's just one pill. The patient often have also statins or other medication for diabetes or kidney disease. So you reduce the pill, the medications, and put several agents into one pill. So single pill combination therapy is now included in all new guidelines. Here is an example of the 2024 guidelines from the European Society of Cardiology, showing to start with 2 drugs in the beginning, and then to increase it to 3 drugs in one pill, which have been shown to be quite effective. We have recently shown also with the triple pill combination that we've developed at the George Institute that it is much more effective than placebo, as would be expected here, but also much more effective than dual combinations if you actually use a triple pill. So you can see here that the triple pill is in the dark blue line, actually resulted in the much better blood pressure drops than when you use two drugs, and that is at low doses. So it actually targets several areas of the body at low doses, and therefore there's no increase in side effects, but much more effective blood pressure lowering from the start. Other new effective therapies that are really promising are injectables for high blood pressure. For the first time, we have some new ways to target blood pressure. So our traditional medications target what we call the renin-angiotensin system, and the main drugs we are currently use are ACE inhibitors or angiotensin receptor blockers. That's all the drugs we have now in clinical guidelines. But with new therapies that target the source of this RAS-angiotensin system, angiotensinogen, we actually have new solutions, RNA-based approaches. And these small interfering RNA agents, actually, such as zilebesiran, and also the antisense oligonucleotides actually completely degrade the angiotensinogen in the liver and results in fantastic drops in blood pressure. The best part is one injection actually results in blood pressure reduction over 6 months. So as this therapy is developing and it shows really promising results, also new trials are coming out, a second and a third Cardia study. They show that they are safe even when you take it with other medications. So it can be quite a game changer. And then my last solution before I finish up is other modern effective therapies, which don't have to be a therapy, but it could actually be for the whole of population, is we have changed the world's salt supply to iodized salt almost a century ago, and it can be done again if we were to do it for potassium-enriched salt substitutes. So some of the data also from the George Institute show that if you switch a household from regular salt to a salt substitute with 25% potassium chloride instead of sodium chloride, it can result in a 13% reduction in strokes and an 11% reduction in deaths in total. And so this was evident for all groups, young, old, male, female, high or low blood pressure. So it's across the board. You can see significant benefit. And these people continued using the salt substitutes after 5 years, which show the taste was also acceptable. So in this study was done in those with a higher risk, people with a history of stroke or 60 years and older, and that showed significant benefit. So my take-home message is the future is here. I think we will see in the next decade quite a few improvements on how to act on hypertension. I've highlighted some of these solutions already during my talk, but I do think we need to find better ways of implementing those. So I thank you.
Thank you very much, Professor Alta Schutte, for your insightful speech. And now it's time for us to welcome to the stage Professor Valérie Fegin, Professor of Neurology and Epidemiology and the Director of National Institute for Stroke and Applied Neurosciences, Auckland University of Technology, New Zealand, to deliver the second presentation on a new paradigm for stroke prevention. So, Professor.
Good afternoon, and thank you for your kind introduction. First of all, I would like to thank the organizing committee of VinFuture for inviting me to this beautiful country and beautiful city, and absolutely fantastic conference. I really enjoy it. I am really honored to give this presentation today about new paradigm in stroke prevention, basically a game-changing strategy to stroke prevention endorsed by the World Stroke Organization and over 200 Lancet Neurology commissioners last year for implementation across the globe, including Vietnam, of course, and that's what we are offering to Vietnamese authorities and clinicians to use in the near future. But before I will go to describe this new paradigm, I would like to share with you some of the numbers demonstrating the scope of the problem in the world and in Vietnam in particular. Over the years, we have been enjoying the reduction in the age-adjusted stroke incidence, mortality, prevalence, and disability-adjusted life years lost. But recently, over the last 10 years, we started to observe a spike in increase in the stroke incidence and stroke prevalence, and particularly in younger people. And I will show you in a minute this slide. What is particularly worrisome is that the absolute number of people who develop stroke, remain disabled from stroke, or die from stroke have increased up to 86% over the last 30 years. And the bulk of the burden of stroke currently in the world is in low to middle income countries, as you can see in these red bars. Vietnam, unfortunately, has a very high, one of the highest in the world, stroke incidence. Compared to New Zealand, for example, it is 4 times greater than New Zealand, age-adjusted stroke incidence in Vietnam. We currently have estimates of the global number of stroke victims every year, 12 million. 7 million of them die every year, and 94 million remain disabled. Stroke remains the second leading cause of death and third leading cause of disability in the world. We now know that 1 in 4 people in the lifetime will develop stroke. In Vietnam, this proportion is even worse. 1 in 3 will have a stroke in their lifetime. And stroke is no longer a disease of the elderly. As you can see, 53% of people affected by stroke are younger than 70 years old. And I used to think that younger than 70 years old is relatively young people. 89%, as I said, or 90% of all stroke burden resides in low-middle income countries. And Professor Alta already showed you some of the figures of risk factors for stroke, which are on increase over the last 30 years. What I would like to emphasize in this slide is that the role of air pollution, almost 30% of stroke burden is due to air pollution, either outdoor or indoor air pollution. Almost 60% due to elevated blood pressure, and almost 30% due to behavioral risk factors. And we believe that those behavioral risk factors, their increase in the prevalence, are the culprit of the increase of stroke burden in young people in particular. In Vietnam, every year, over 200,000 people affected by stroke. Stroke is the number 1 cause of death in Vietnam. Very significant problem. And the number of affected people with stroke is on increase, almost linear increase over the last 30 years in Vietnam. It is also a very costly disease. If you look at just the indirect and direct cost of stroke in Vietnam, it is in the order of $10 billion a year. The bulk of the burden, economic burden of stroke, like a burden of incidence and prevalence and disabilities, also resides in low middle income countries, shown in these red, yellow, and green bars. We now have almost $900 billion lost by the world economy due to stroke. By 2050, this number will almost double if effective preventative strategies are not implemented. And you may ask why the preventative strategies are not effective and what strategies we have in place to use. This been addressed almost 40 years ago by Professor Jeff Ross from Oxford University. He emphasized that the most cost-effective strategy for stroke and cardiovascular disease prevention is a population-wide strategy, where the whole population, regardless of the level of risk, are exposed to some interventions, like smoking cessation intervention, or improved lifestyle. It is most cost-effective because it addresses not only stroke, but all other non-communicable disorders. But there is still no country in the world where this intervention is implemented in full because of the relatively high cost of this intervention. If you look at the root cost of all cardiovascular and non-communicable disorders, it is poverty. It is very costly to address that issue. On the other hand, on the other side of the intervention strategies is high cardiovascular risk strategy. It is good in terms of exercises integrative approach. Rather than addressing individual risk factors, this strategy is based on the absolute cardiovascular risk. And if the risk, 5-year risk, is greater than 15%, then the person considered high cardiovascular risk individual, and he or she will be prescribed either blood pressure or lipid-lowering therapy. But the problem with this strategy is that it misses out 80% of people with low and moderate risk, and these are exactly the people where most strokes and heart attacks come from. And it's heavily targeting a pharmacological treatment. For people who have low and moderate risk, they are falsely reassured of their safety from cardiovascular disease. And I will show it on this example, like 40 years old man, smoker, with hypertension, but his 10-year absolute risk is only 0.6%, as determined by atherosclerotic cardiovascular risk calculator. Obviously, very low risk. And that person will start thinking, oh, I am protected. I could start junk food or stop exercising. But if you measure his relative risk, it is 3.2 compared to someone of his age, sex, ethnicity, but without additional risk factors. And in this case, this person and his doctor would think about treatment of his hypertension and some lifestyle changes. Last but not least, the latest systematic review and meta-analysis of the World Health Organization experts showed that high cardiovascular risk strategy has no impact whatsoever on the incidence of mortality from cardiovascular disease, and they recommended not to use this strategy in countries where the strategy is not introduced, and reconsider these strategies in countries where it's already used. So about 10 years ago, we came up with the idea of digital tools for primary and secondary stroke prevention, free to use for lay people, for the community, stroke riskometer app, and prevents MD software for clinicians, nurses, and doctors. These digital tools have received a number of international and national awards. And I will just show you briefly evidence to support the use of these digital tools. A number of randomized controlled trials, either recently finished or ongoing on the right side, and these are the results of some of this trial. In New Zealand, the trial showed that the use of stroke riskometer results in about 4% stroke incidence reduction a year. A trial in Malaysia, this data still not published, showed effect of the stroke riskometer in reducing cardiovascular risk. As you can see here, statistical significant improvement of awareness about stroke risk factors. And most important trial was recently done in Brazil on use of either polypill that Professor Alta showed you, a combination of blood pressure lowering and lipid lowering medications shown here, or placebo alone or in combination with stroke riskometer app to reduce systolic blood pressure and improve lifestyle at 6 and 9 months in low cardiovascular risk patients. This is the first ever in the world trial that tested preventative intervention in low cardiovascular risk people. As you can see, systolic blood pressure needs to be below 140 and age 50 to 74. These are the inclusion criteria, the baseline characteristic of treatment and intervention groups are very comparable, suggesting good randomization, and the results were extremely surprising. That's a real revolution in primary stroke prevention. As you can see, the combined use of polypill and stroke riskometer compared to placebo usual care resulted in more than 10 millimeters mercury reduction of systolic blood pressure, you can see on this graph. It also resulted in reducing absolute cardiovascular disease risk, improved physical activity, reduction cholesterol, all statistically significant effects, improved use and ease of use and usability of the stroke riskometer app. And in conclusion, this trial showed that combined use of polypill and stroke riskometer is equivalent to 50% stroke incidence reduction per year. It is enormously large, clinically significant effect of the intervention. And eventually, World Stroke Organization recommends to use that simple screening tool using stroke riskometer with motivational strategies built in, prevents MD and polypill in combination. This combination will result in the reduction of stroke incidence by at least 50% when used widely on the population level. Finally, I would like to thank my team who was involved, is still involved in the development of these digital technologies, and thank you for your attention.
Thank you very much, Professor Valerie Fejin, for your amazing presentation on the new paradigm of stroke prevention. Distinguished guests, ladies and gentlemen, and now we are honored to welcome to the stage Associate Professor Ngọc Quang Nguyễn, Vice Director of Vietnam National Heart Institute, Bạch Mai Hospital, Vice Head of Department of Cardiology, Hanoi Medical University, to deliver the second lecture, the highlights from Cardiology 2024, which can be used to transform cardiovascular care pathway in Vietnam. So now it's your time.
Thank you. Thank you, everyone. And first of all, I would like to thank the organizing committee to give me a chance to stay in the stage to share some of our thinking about how we can transform the cardiovascular care pathway in Vietnam. And basically, we try to see from the point that we see a lot of achievement in cardiology this year. I have no conflict of interest. So basically, when we see the cardiovascular burden over the world, we see the ischemic heart disease is most prominent. A little bit different compared to in Vietnam, stroke is more prevalent than that. And also we see the other thing that a few risk factors here, you can see here the air pollution is important, contribute to the cardiovascular disease over the world. Similar in Vietnam. So in our country, we need to facing a lot of things. Not only the hypertension, but also the high cholesterol and also the air pollution. And this is the data from Vietnam, and you can see the different way. Half of the cardiovascular disease in Vietnam is a stroke. And that's why we are a little bit different compared to the other part of the world. Why it happened? And we can see the data here. We see the time trend of the cardiovascular risk factor over the country. We can see here these data from the Southeast Asia in terms of hypertension, this data from the high cholesterol level, and this area mapping about the smoking. And we can see that in the region and also in Vietnam, and especially in Vietnam, our data showing that the time trend of the hypertension 10 times more than the average rates over the world. So that's why in Vietnam, we need to facing a lot of stroke. And that's why, as previous two speakers already mentioned, we need to dealing with the hypertension to prevent the stroke in Vietnam. But this is only one issue. Another issue we need to facing is also the cardiovascular disease. And in Vietnam, because we are so crowded, and we need to shifting the delivery care model a little bit different way. And this is a way we move from the provincial hospital to the community space to dealing with the huge burden of cardiovascular disease. It's not only the coronary heart disease, it's not only stroke, but also the hypertension and the other thing, heart failure, the patient survival after the shock, a lot of things we need to deal with. So that's why the cardiac care model needs to be switched into the community. And so this is the context. And if we look into the what is going on in the cardiologies, and we see a lot of late-breaking trial. I don't want to mention because it can bother you, but we see some trend here, and almost the topic here is summarized through the AHA conference this year. We see, like in cardiologies, we have a lot of treatment already have redefined. Like the previous speaker already mentioned, we have a new therapy, injected drug to treat the hypertension, to treat the high cholesterol. So this is the new future, very bright future, to make the patient more adherent to the treatment and also to prevent the major cardio death later on. Second point is we have a lot of new technique and treatment and also revolution in the cardiovascular vascular disease. We have a lot of tools to do, for example, intervention for the arrhythmia, intervention for the heart failure, intervention also for stroke. We have a lot of things can be done. And now actually we can save at least 6 years in survival for the patient. Compared to the oncology patient, we only can save about 0.6 months. So this is a different story. And also we have another trend like we see a lot of smart cardiologies. We applied AI into daily practice. A lot of things can be done with the AI. Echocardiography, MRI, ECG, and now a lot of things can be treated and individualized treatment by AI. And also another thing is very, very important, like you have a lot of innovation in prevention and global implementation. Why it is important? Because we have evidence. We don't have the way to imply this one into the daily practice. And also we have another thing, like we have a multidisciplinary area when cardiologists can combine and working with the other specialty in medicine. So how is the emerging trend in cardiology? I can summarize you here trend in cardiology over the year. First of all, we see the holistic approach management. We not only focus for the patient, we also focus for the spiritual, we also focus for the family, for the context, for the environment. So a lot of things need to be done. Another thing is very early and multidisciplinary prevention. Now we think about the prevention prenatal. So we try to identify who have a high risk of the CVD later on. So this is very early, and we can do a lot of things together. And for the treatment, we have a very aggressive and individualized treatment. A lot of rare disease in cardiology can be done. And we have a very good response and reliable daily care system. And this area is area we can do a lot of things to improve in the country like Vietnam. And the last one, we have tried to combine everything together, working like a team. So this is a trend in the cardiology this year. So what beyond the cardiologies? So beyond the cardiology, we see that they try to combine a lot of things together. And only a few years, in 2023, we have a concept like cardiovascular kidney metabolic syndrome. We try to combine a lot of things together because when we did to prevent them, we can prevent the cardiovascular death. We also can prevent the progression of the kidney and also the metabolic burden for the patient. So this is a new concept beyond the cardiologies. And another thing is important, like beyond that, we have a lot of things need to be done. When you can see here the long set, like the symbol in the medicine, they have a new journal focused for the planetary health, talking about the life, our physical world outside, because this is affected a lot on our life. And the second one is the digital health, because this one is really can improve our burden and also can improve our survival. And the last one, they mentioned about the longevity. So longevity is something like you need to mention now. And if we put everything together, now we see what was going on in cardiologies. The cardiologists must focus not only the cardiovascular health, but also the longevity. So that's why dementia becomes our target to prevention when they treated the hypertension or atrial fibrillation. So this is something like we need to think a little bit more beyond the cardiovascular medicine. But in reality, there is a big gap between the research and practice. Here I mentioned the few study late tracking trial just announced in this year. And you can see here a lot of data talking about the injected drug for the hypertension, injected drug for the the high cholesterol level, a lot of AI study showing that AI can support very good for the physician. But in reality, there is a lot of study try to identify how to implement this data, this evidence in daily practice. And you can see here, China, Nigeria, India. So we can think about the future when Vietnam can do something similar thing, when we apply the same thing and give back to the world which model is good for us and also good for other countries. So how did the Asia contribute to the cardiovascular medicine? And in reality, this is summarize the top research selection in the 2023, and you can see here all the author here from the South Korea, Japan, China, India, and showing this is area Asia, including Vietnam, can contribute to the world. So we can see epidemiology, prevention, shock. Why? Because we are so crowded. The population is too big, so that's why we have enough data to showing the data about epidemiology and also the shock. About the intervention, why? Because Asia very good hand. Intervention, very good way to go. So they contribute to the intervention. And we also have AI, new technology. Why? Because we have a very big population, can testing easily and very fast the model using the AI. And the last one, we have something very interesting. We have evidence showing that the changes of medicine is good for the cardiovascular patient. So this is the future. This is a way we can contribute to the world and also to help us. So this is so I just showing that it is something like our opportunity to transform the cardiac care, even we are staying here in Vietnam. Of course, we don't have enough money to do the very expensive and fancy study, but however, we can still do a lot of things. We can push the boundary for very specific cardiovascular issue in our region, because in Vietnam, patients always came late. We have a late presentation of the acute STEMI. We have a late presentation of the stroke. We have a very complex CVD issue with a multi-comorbidity, high bleeding risk. So a lot of things we need to do and we can do for our patient and also for the world. We also can develop an implementation, a new model for cardiac delivery, because this can use our traditional. We have a very strong background based on the family community to help the people. And this is why we can develop the new model of delivery care system. And of course, smart cardiology and digital health, we have a lot of things can be done. screening, monitoring, risk stratification, adjusting the dose, educating, and also the caring. How to give the patient some emotion by AI. This is the future, easy way to go, but we can do it and we can improve our daily care. And the last one I want to mention here is rehabilitation is really important, and also prevention through the traditional health, exercise, and medicine. We have a very huge and very strong backup and history. A lot of things can be done, and actually we can do a lot for the future and for our patient. So if I put everything into the care pathway, so what we can do here, for example, like we have from the primordial prevention until the secondary prevention after the event. A lot of things we can do here: smart screening, proactive prevention, polypill approach, all the way on therapy like renal denervation. We can do for everything for the patient. And in reality, in the acute phase or chronic phase, AI can help us. So a lot of things can be do, and even we stay here in Vietnam, we still can contribute to the world. So this is a way, for example, like very specifically for the acute coronary syndrome, we can do everything from the genetic consultation, from the prenatal prevention. We know that what type the patient should have a very high risk for the CVD later on. And later on, we have a lot of things to do. We can do pre-treatment with AI. We can diagnostic very quickly by the AI based on EKG. And then we transfer them to the nearest center to do the primary PCI. And after that, we can smart monitoring. We have a waste ability to do the cardiac version for the patient if they have a fetal arrhythmia. So a lot of things can be done. And after patient came back home, we have a lot of things to do with the rehab and proactivity habilitation. So this is a way to go. And I think that based on this care pathway, we can do a lot of things together. So this is a very short time, but however, I think that I think that cardiovascular burden is really a global issue and should be management like a very comprehensively. Comprehensive meaning that you need to combine, to collaborate together to deal with a lot of things beyond the cardiovascular medicine. Second thing that we recognize that there is a significant implementation gap between the evidence and daily practice. And that's why there is a lot of opportunity for our scientists, our doctor, to collaborate, to contribute to the work, and also to improve our healthcare system. Thank you very much.
Thank you very much, Associate Professor Ngọc Quang Nguyen, for your amazing presentation. Professor, could you please turn back to the stage so that we can come to panel discussion today. So now it's time for the symposiums today, panel discussion. So I would love to welcome back to the stage Professor Alta Schutte, Professor Valerie Fegin, along with our distinguished speakers, Professor Duc Phu Bui, Director of Cardiovascular Specialty and Chairman of Cardiovascular Committee of the VinMec Healthcare System. And also, I would love to welcome Associate Professor Duy Ton Mai, Director of Stroke Center, Bạch Mai Hospital. Please welcome our distinguished guests to join the symposium's panels today. So now it's time for the Professor Alta Schutte who will moderate the panel. The stage is yours. Thank you.
Thank you very much, and thank you to the speakers. I think we've had a good follow-up on to each other's presentations. I would like to open this discussion because we started all the way from primordial prevention, which you mentioned, which affects everyone in Vietnam, all the way to those who actually suffer from a stroke and making sure that they get the proper care. Of course, the care of patients with stroke is very expensive, hospitalization, whereas prevention also has its challenges in terms of population-based strategies. So what I would maybe direct my first question to Professor Fagan is we have solid evidence of interventions for population prevention and for treatment in primary care, but how can we afford that appropriately? How can governments afford that? Because much of the government budget go towards secondary care, tertiary care.
Yes, thank you. This is a very good question. Everybody agrees that prevention is important. When we talk to policymakers, none of them ever said it's not important. It is important, but we have no money to do it properly. And where to get funding for stroke prevention? As I mentioned in my presentation, about 30 to 40% of stroke burden is due to lifestyle risk factors, such as excessive salt intake. You showed in Vietnam 2 to 3 times greater salt intake than the level recommended by the World Health Organization, excessive alcohol intake, smoking. Over 40% men in Vietnam smoke cigarettes. All of these are important risk factors for stroke. And it was proven in many randomized controlled trials that the best strategies to reduce exposure to these lifestyle risk factors is through taxation. And no one likes taxation, no one wants it, but if people would know that taxation or revenue from taxation will go back to their health, they would have free health insurance, they will have better access to care, maybe even free access to care. They will be supported financially by the government if they become disabled. They most likely would say yes, but that needs to be a very transparent process of taking money from taxation and spending it on people. I can give you one example. I was told a couple years ago in Philippines, they introduced a significant taxation on alcohol and gave all the revenue from that taxation to the Ministry of Health. And one guy who works for the Ministry of Health, he told me that they did not know how to spend all the money. There are so big money came to their budget, they have no way to spend it all. So not only healthcare prevention can be improved through the taxation on unhealthy products, but other social problems could be solved. Even poverty could be, reduced. So I believe the source of funding is there. It is just goodwill of policymakers, governments, to use this strategy.
Thank you. I agree. That's often not popular, but it has some good evidence of effectiveness. I was also thinking about the situation in Vietnam, and maybe direct the question to Dr. Ton, whether you think that these sort of strategies would be implementable, or what other strategies do you think are low-hanging fruits to really change the situation in terms of this high levels of hypertension that was just reported and stroke incident?
In Vietnam right now, we know that the prevalence of stroke very high. We estimate that more than 2,100 new cases every year. And the mortality is the same. In our study, so that the death during 90 days about 10%. And the disability is also very high. So I think 3 problems for stroke in Vietnam, including the prevalent death and mobility rate very high. So I think in the future we have the national stroke program to reduce 3 problems. So in the near future, maybe we will discuss with Ministry of Health to have in plan how can we deal with this stroke problem right now. Maybe we have to method to reduce to deal with primary prevention to reduce the prevalence of stroke, and we also have to some method for inhibitor to reduce the mortality and disability. So in this conference, we have to chance to discuss with you, especially in Professor Valerie Wagen. And tomorrow afternoon, we also working with miniature panel. So maybe we will present a plan. Maybe we need to 10 method to do reduce 3 target in the future. So today we also to discuss with Valerie, Professor Plagagi. So we would like you have more experience in the apply for developing country in the world, such as Brazil. So right now we would like to have to recommend for miniature panel to how we can implement the strategy at least next 5 years to how can we deal with this problem.
Yes, thank you. I think that's completely right. This gap that was also mentioned between clinical trial evidence and implementation is some of the major challenges we have. I also want to direct the question to Professor Dukfu from the VinMec group. So I suppose you are more in the high end also for patients with health insurance. Do you think some of the developments also for the VinMec group can open pathways for the broader population?
So we know the implementation of 4B medicine, predictive, preventive, personalized, and participatory. In cardiovascular care, management is very important. And now we focus how we can do step by step. And I want to know also the standard implementation of is very significantly different between the country, the developed country, the developing country, the underdeveloped country. And so could you elaborate further on that? And what solution might help bridge the gap? We try to do the first step, how you can apply the new technology and new procedure and new approach to approach the patient, and we selected the accreditation from ACC, and I think this is the way to cover the quality, the experience, the access, and with optimizing the cost and so on.
Yes, I think the whole implementation, as you say, is also part of the challenge. And I think we have to think, you mentioned, Professor Ngokwa, that the opportunities are there. There are very many opportunities, but why are they not yet implemented, and what can we do? What is the one you think which has the most potential for rapid implementation, and what is needed to achieve that? We have to have action, right?
I think that in terms of cardiovascular disease, the most easy way to go is a polypill. Polypill can easily to do, because actually in reality, a lot of patients really don't want to take a lot of drug. And in reality, the patient have a lot of comorbidity. So that's why the list of the drug they take is very long. And so polypill is something we need to focus on, not only for hypertension, but also the other thing like coronary disease and heart failure. Another thing I want to mention here is the role of the patient themselves. We already developed a program, like a national program, to management the hypertension in community for more than 15 years. And when we do the intervention in communities, one thing we recognize that if the patient can witness the reduction of the blood pressure, then they can follow up the treatment easier. So that's why at this point, we try to encourage them to measure their own blood pressure by themselves, by the digital device, so they can see what was going on. And if they stop the drug and then the BP back again, and then they need to take again the drug. So in stroke, I think it's similar thing. If the patient can see the stroke risk, and then they can follow and they can maintain the adherence to treatment easier. And also, like, if they already know about that, they have a responsibility for themselves. Because this is a very chronic disease. Cardiovascular disease is something chronic. It is like a lifelong. And every people can take their own responsibility, even the money. So that's why they need to know about that. And that's why we need to focus more for education, to let them know, and also to give them a lot of opportunity to see what was going on, like BP, like a stroke risk, something like that. And then they can follow that, they can recognize their own responsibility, and they can change their life.
Yes, I think you've raised a great point, and that is what we also call patient engagement and activation, to understand their own condition, to know what they should do, to track their own health, and to take that responsibility of monitoring their own health and taking their medication. I will hand over to Prof. again, but I also want to invite anyone from the audience who may have a question to also raise your hands. Thank you.
Yeah, I would like to add to this very important point of motivation of the patients. It has to do with adherence to medication, has to do with following doctors' recommendations about lifestyle, and that's what we found particularly challenging to improve. And one of the barriers in proper motivation we found is labeling people as low to moderate cardiovascular disease risk. If you label a person or tell any person who has low risk that they are low risk individuals, they will do nothing. Even if they smoke, have hypertension, excessive weight, because they are falsely reassured that they are protected from cardiovascular disease. So that's one of the things which we try to dispel with our digital technology, and also 4 other major motivational tools which are built in our technologies to motivate people to medication adherence, to follow lifestyle recommendations. Thank you.
Great point. Are there any questions from the audience?
Yes, thank you very much, our distinguished panelists. And now it's time for the Q&A session. That I can hear your voice with the questions for our panelists today. Yes, the man in purple. So my staff can assist him with the mic. Yes, please.
Alo. Tôi có câu hỏi, có vị có thể là đeo microphone này dễ hơn. Microphone, please. Do you have it? Tôi có câu hỏi chỉnh cho ông New Zealand. For New Zealand speaker. Thì câu hỏi đặt ra đây, tôi không phải là chuyên gia về cái này, tôi chỉ là bệnh nhân thôi. Thì tôi thấy là khoa học y tế của nhân loại là đi những bước rất dài, nhưng mà mỗi năm này chết mất 10 triệu người, và số chết đó còn nhiều hơn nữa. Thì cái sứ mạng của khoa học nó ở chỗ nào á? Mà nghiên cứu thì nhiều mà chết thì cũng lắm, thì không biết là nghiên cứu cái gì. Đây là điểm thứ nhất. Cái điểm thứ hai á, là tôi cho là toàn đổ là không có tiền, mà trong đó là tiền hút thuốc và cả cái tiền khác ở chi cũng rất nhiều. Đây thì tôi thấy là liệu rằng cái trình độ của nhân loại nó đang gặp phải những cái vướng mắc về trí tuệ, hay là bị thiểu năng trí tuệ. Công cụ có thì không được dùng hết, rồi là tiền thì lại thiếu. Đây, nhà khoa học thì nhiều nhưng mà tiền thiếu, rồi công cụ không đủ. Rồi cái tiếp theo nữa là nhiều cái bệnh biết rồi nhưng cũng không chữa được. Chết 10 triệu một ngày, như vậy chết gần 30.000 người, chết nhiều thế mà. Đấy thì tôi thấy là vậy thì trước mắt của những con người vĩ đại này thì các vị đã đảm nhận được cái sứ mạng cứu con người đến mức độ nào, hay là chỉ là đến dự hội thảo với nhận giải để đi về. Thì tôi thấy là muốn là vậy thì chúng ta có giải pháp gì đột phá không để cho nhân loại không? Chứ còn từ trước đến nay cái bệnh đột quỵ đây có thể lâu lắm rồi cũng giải quyết được chứ.
Vâng, xin cảm ơn ạ. Xin cảm ơn khách mời ngày hôm nay.
Cái đó đề nghị.
Vâng.
Đề nghị cả ngài cho cái hướng này thì chúng ta nên có một cái tầm nhìn mới không? Đấy, hay là cái giải thưởng này nó chỉ là một cái để còn là đánh bóng là chính, để phải có một cái tầm nhìn mới cho nhân loại không?
Cảm ơn khán giả. Vâng ạ, chúng tôi ghi nhận những đóng góp ý kiến và câu hỏi của ngài, và chúng tôi cũng sẽ tổng hợp để gửi tới chuyên gia có thể phân tích được những câu hỏi này. Tuy nhiên thì những chuyên gia tại đây chúng ta sẽ nói nhiều hơn về những công cụ trong việc có thể phòng chống đột quỵ cũng như là các bệnh về tim mạch, nên là chúng ta sẽ cùng đến với những câu hỏi chuyên môn hơn để đặt ra cho các khách mời. And now we receive a lot of questions from the audience online and offline, and the questions you have heard is from a patient. He's not an expert in the field of cardiovascular or stroke outcomes, but now we receive a lot of questions from our expert in the field of public health. I want to send this question for Professor Fei Jin. So the question is, what are your predictions about the development of new technologies in the field that will advance personalized medicine?
Yeah.
Professor, please.
Thank you. That's exactly what we are developing and offering in other countries, including Vietnam. Individualized, personalized primary and secondary prevention strategies, which are motivational for the individual and effective based on the local and international guidelines. And at the same time, they are specific to the individual. The stroke riskometer app, which I mentioned, is free to use, download, so it's translated in 25 languages, currently available for over 5 billion people in their native languages. Prevents MD also translated in about 20 languages. So these are the tools which are ready to be used, and that's what we are recommending to be implemented in Vietnam.
Thank you very much, Professor Fei Jin. And now it's time for one more questions from online platform, from Zoom chat. And this question is for Professor Ngọc Quang Nguyễn. So the question is, what milestones does Vietnam need to achieve in coming years to develop this field?
Well, you mentioned about the milestone we need to do for
Yes.
the cardiologists in Vietnam, and I think that the milestone here is we need to base on this the prevalence of the patient have control the cardiovascular risk factor like hypertension, like cholesterol level, like stop smoking, something like that. Because this is something we can achieve, we can see easily. The other thing we can see is how the other milestone we need to do is how we integrate it with other specialty. For example, like in the world, we have a lot of things to do with the oncology. So we need to working very closely with the oncology doctor to take care of the cardiovascular burden for them. Another part is OB&G. We have a lot of problem with the pregnancy woman with hypertension. So this is the future. So this is a way to go. And I think that another milestone need to be done is the way we're working together in like a multidisciplinary team for the patient. For me, this is the most two things important. The other thing is might be not easy to measure and also not easy to done with.
Thank you very much, our distinguished panelists, for your questions. And now I think that we still have one more spot for the very last questions from offline audience. And yes, so please, thank you.
Hi, thank you for the opportunity. Great presentations and wonderful speakers. Yeah, my name is Bala Nair. I'm an associate of Professor Valerie Figan, and I'm from Auckland University of Technology, New Zealand. I want to go back to that person who has pointed out a question, and I have used this translator mic really good. You know, I was able to understand that in English. So his question was around the vision of the people of Vietnam, that how to change their vision, their attitude from a smoker, an alcoholic, to someone who is looking after their health. So, which is a very important question. And I think that will be a valid question to the judges here. Yeah.
Maybe one of our white Vietnamese colleagues to address that.
You mentioned about the way how to transform the one like a smoker into the non-smoker patient, right? So I think there is two things we can do together. One thing is themselves. They need to be educated by themselves. They need to be recognize their own responsibility. The second thing is really important is the environment around them. For example, like in Asia, we have a model from the Singapore. They have the new way like the green plan. So everywhere around the like a cities, the house building, they create the environment to promote the people to change the lifestyle. So this is another way to encourage the patient to follow. So when you look into the Vietnam, a lot of marathon, every people run every day. So this is a way to encourage people around to follow, to change the lifestyle. So I think that in reality, there is only, we need to combine two things together. They improve their own responsibility by educating, and the other thing is we create the environment to promote the lifestyle changing.
Thank you very much, our distinguished panelists. And that is conclusion for today's symposium. And it also wraps up our symposium today about the innovations of transforming in the cardiovascular and stroke outcomes. Thank you very much for your participation, and thank you very much, our panelists, with all your informative presentation and discussion on various issues related to public health. One more time, thank you very much for joining with 4 symposiums in the Science for Life Symposium today of VinFuture Prize Award Ceremony. And we would love to welcome you to the breakout sessions for the audience. Our panelists and prominent local scientists to the field can connect and network with each other. You can join 3 different rooms for 3 assigned topics, and the session will last for 1 hour and close at 15:45. And don't forget to watch VinFuture Prize Award Ceremony premiered on VTV1 Vietnam National Television on tomorrow, December 6, 2024. One more time, thank you very much for our panelists, our top brain of the world, top scientists of the world coming here to Vietnam. Thank you one more time. Goodbye and see you again.
Thank you. Thank you.